Hello and welcome to this installment of COVID-19, What Pharmacists Know Now. This video focuses on the role of statins in COVID-19. My name is Turgeon. I'm a clinical pharmacy specialist at the Vancouver General Hospital. As a clinician, I primarily practice in the ambulatory heart function and internal medicine clinics. As a researcher, my primary focus is on cardiovascular pharmacotherapy. It's important to acknowledge how much and how quickly we're learning about COVID-19, and so the information in this video really is current as of the day it's recorded, and we might learn more in the coming days to weeks. The learning objectives for this video are to describe the potential mechanisms for how statins might work in COVID-19, to summarize the evidence in COVID-19 as well as other related conditions, and ultimately to provide some evidence-informed recommendations based on the current body of knowledge. As a refresher, statins are medications that are primarily used as agents to reduce the risk of cardiovascular disease, both in people with existing cardiovascular disease as well as those at high risk, such as people living with diabetes. The main way in which they do this is by lowering LDL cholesterol and other atherogenic lipoproteins, but statins also have other beneficial effects, what we term pleiotropic effects, that might be useful both in cardiovascular disease as well as other health states. This potential link between statin use and COVID-19 first came to my attention on March 18th when I read a blog post on the American College of Cardiology entitled, "Is there a role for statin therapy in acute viral infections?" And since then, other commentaries and editorials have advocated for either the use of statins in COVID-19 or at least the study of these agents. The buzz around the role of statins in the management of COVID-19 really came to a head when the Massachusetts General Hospital's critical care guidelines for COVID-19 management were posted on Twitter on the Harvard Pulmonary and Critical Care's Twitter account. Within these guidelines, in the therapeutics section of their algorithm, they actually advocated for the consideration of using statins, particularly in patients who were admitted to the ICU. So how might statins help with COVID-19? Well, the more severe manifestation of this illness tends to present with widespread systemic inflammation. And we see this clinically by measuring biomarkers of inflammation, which are typically elevated, including CRP or C-reactive protein, as well as interleukin-6. And this tends to manifest clinically with end organ damage, particularly of the lungs and of the heart. So patients will present with acute respiratory distress syndrome, as well as shock and heart failure. Since inflammation plays an important role in more severe manifestations of COVID-19, a medication with anti-inflammatory properties might therefore be potentially useful. And in fact, in experimental studies, statins have been shown to decrease inflammation. Importantly, they actually blunt the production of pro-inflammatory cytokines, including CRP and interleukin-6, which, as I mentioned earlier, are typically increased in severe COVID-19. In addition to that, statins have direct beneficial effects that leads to decreased pulmonary vascular injury and ultimately decreased lung injury. Now, with these being experimental studies, they have important limitations. Most notably, these are primarily in vitro and animal studies. On top of that, these are generally done assessing bacterial infection. And so none of these studies that have been done so far have actually assessed the effect of statins on inflammation in the context of viral infection in humans. And so these models may not generalize to a viral illness. So what's the evidence for statins in COVID-19? Well, as of today, there simply is none. As a result of that, we really need to look at similar conditions to see what might be the role of statins, and is there any suggestion that they might be beneficial for COVID-19. So to do that, we really have to extrapolate from evidence of other similar conditions. In this case, I've selected a few conditions to highlight, primarily community-acquired pneumonia, influenza-like illnesses, acute respiratory distress syndrome or ARDS, as well as chronic obstructive pulmonary disease, to give you a sense of how likely statins are to be successful for COVID-19. Let's start by talking about statins and community-acquired pneumonia. These studies were generally done because of the identified pleiotropic effect of statins on the inflammatory pathway. And so what we have as far as the best available evidence is a meta-analysis of 13 studies, 12 of which are observational studies. In total, 250,000 people with community-acquired pneumonia were studied, and overall within these studies, statins were associated with a lower risk of death compared to no statin. But it's important to consider the limitations of this study, particularly the studies included. As I mentioned, most of these studies are observational. In fact, over 99% of the patients in this study were allocated to statins in a non-randomized way, which means we have to consider things like bias and confounding, because patients who are given statins are systematically different from those who are not. In fact, when the authors of this meta-analysis looked at studies based on how well they accounted for potential confounding and bias, what they found was that the better the study design, the better it adjusted or used other methods to minimize bias and confounding, the lower the magnitude of association between statins and better outcomes. Now, this can be explained by the fact that people who take statins in the real world are typically very different from those who do not. And in fact, in several of these observational studies, it's been identified that people who take statins tend to have better socioeconomic status, tend to have greater access to health care, and so have better adherence to preventative care, such as cancer screening, vaccines, and quitting smoking. And these patients tend to also have fewer markers of frailty, like needing advanced directives or being in a long-term care facility. In other words, the bottom line is that the association found in these studies is confounded. As a result, all of these studies that have assessed statins in community-acquired pneumonia are compromised by confounding. In other words, they really don't give us a reliable estimate of what sort of benefit statins could have in community-acquired pneumonia, let alone COVID. Now, what about viral illness, such as influenza or even a viral pneumonia? Well, it turns out that studies have been done on this too. There have been at least 4 cohort studies assessing this, which have included approximately 15,000 patients. Now, generally, these are hospitalized cases of either influenza or viral illness. And overall, 3 of the 4 studies included here did find an association between statin use and a reduced risk of death in people with these illnesses. But, again, the same limitations apply here as what we found with community-acquired pneumonia, which is to say that people who take statins in a non-randomized way are different from those who don't take statins in a non-randomized way. And therefore, all of these associations run into the same problems. So in both of these situations, the evidence is compromised by confounding. It is possible that statins have a benefit, but the only way to know for sure is to remove that confounding by randomizing patients. Now, we don't have strong randomized controlled trials for either of these situations, but we do in 2 other health states that we'll talk about. The first of these is acute respiratory distress syndrome, or ARDS, which of course is a severe manifestation of COVID-19. Now, the best evidence that we have for statins in ARDS is an individual patient-level meta-analysis of 6 randomized controlled trials at low risk of bias. Now, you'll note that this is actually the best level of evidence that we could have for any condition, so this is actually fantastic news that we have this data. Within this meta-analysis, about 1,700 patients were studied, mostly with moderate severity ARDS, and most of these patients actually had ARDS as a result of sepsis. And in fact, many of them had it as a result of pneumonia, so highly relevant for the question of COVID-19. Statins were mainly used at moderate intensity or high intensity, and all compared to placebo. The outcomes of interest here were death, days off the ventilator, and serious adverse events in the first 28 days. Overall, for ARDS, there is no benefit to using statins. There is no difference in death, days off the ventilator, or serious adverse events with statins. Now, some have hypothesized and suggested that ARDS actually has different subtypes, including one that's hyperinflammatory and that one that's actually hypoinflammatory. And they've hypothesized that statins would only be beneficial if there is a high level of inflammation. But in fact, this was studied in this meta-analysis and subgroup analyses, and there was no effect of statins regardless of how you sliced it. And so people, even with the highest levels of CRP, a marker of inflammation, did not benefit from statin use. And so this is our first suggestion that statins may not be beneficial at all in COVID because it's not beneficial in people with ARDS. Some have argued that by the time a patient is in ARDS that it's too late and that we should actually be using statins earlier on in the course of illness to prevent the progression to severe illness. So for COVID, that might mean using it as soon as somebody is found to have COVID or as soon as they develop mild influenza-like symptoms. I think it's useful to look at the evidence in COPD to help guide whether that would be useful or not. Because as we know, COPD is generally an inflammatory condition, and it's typically a situation that has long periods of convalescence, periods of exacerbations, and then progressive worsening. And so statins have been studied in COPD. In fact, the best trial we have is an RCT at low risk of bias with about 800 patients. And these patients were at high risk. They were at high risk of having more COPD exacerbations. So they're the perfect patient population to study. And so within this randomized controlled trial, simvastatin at a dose of 40 milligrams daily was used compared to placebo. And by the end of long-term follow-up, there was no difference in the number of exacerbations for COPD that people experienced, whether they received a statin or placebo. So this ultimately provides another piece to the puzzle that statins might not be useful for pulmonary disease, particularly for the prevention of progression of pulmonary disease. After the publication of these trials of statins in ARDS and COPD, there's an editorial published in the New England Journal of Medicine entitled Statin Strikeout, and there's a sentence from there that I think is particularly salient here. Had we accepted the observational data at face value, we might have spent the cost of the trial many times over in useless treatments before recognizing our errors. Now, I think this is important to consider in the context of where we are with the management of COVID-19, particularly in the fact that we don't have any evidence-based pharmacological therapies at this time anyway. So I think it's important that anything that we use, we do so in the context of a trial so that we can identify whether it's actually beneficial. So with all of that said, here are my recommendations for you on the use of statins in COVID-19 as of April 2nd, 2020. So in those patients with confirmed or suspected COVID-19 who are already taking a statin and have an appropriate indication to do so, continue statin therapy. If patients have an indication but they're not yet on one, start a statin. However, if they don't have a cardiovascular indication for a statin, don't start one. And COVID-19 is not an appropriate indication for statin therapy at this time. The only way in which this should be done is if it's as part of a clinical trial. It's specifically going to be addressing the research question of, are statins beneficial in COVID-19? What's the bottom line for statins in COVID-19? Well, at this point, there is no evidence for the use of statins to improve COVID-19 related outcomes. There's no convincing evidence that they actually work for other related conditions, including ARDS. And so at this stage, COVID-19 is not an indication to use statins. Thanks for listening, and I'm happy to address any questions you might have. Here's my contact information. Please get in touch. Thank you and stay safe.